Thank you very much for the invite. And while I share my screen, I'd like to place on record my gratitude to the organizers for giving me this opportunity. And over the next 10 minutes or so, I should be speaking about the second line therapy after immunotherapy. Are there any specific choices? Greetings from my institute, the Armed Forces Medical College at Pune. So when the immune checkpoint inhibitors are used in the first line of therapy, as a single agent, they have a response rates of around 20-30%, whereas in case of a combination with a chemotherapy or an immune checkpoint inhibitor combination, it's a response around 50 to 60% is there. What depends on the therapy beyond the second line are the factors mentioned on the slide. The previous therapy the patient has received, the type of the response, whether the progression is oligometastatic or a systemic kind of a progression, what is the burden of the disease, and what is the patient performance. So the progression on this combination can be classified into three main kinds of classes. The early systemic progressive disease, which is within 3 months of initiation of treatment. The intermediate systemic progressive disease, which is 3 months to 2 years of initiation of treatment. And late systemic progressive disease, which is at least 2 years after initiation of the combination therapy. So we'll stick to the agenda in the following three main headings. What are the second line options prior to when immune checkpoint inhibitors had come into the foray? What are the data for options of use of drugs after second line immune checkpoint inhibitors? What has been happening so far? We used to use a platinum-based chemotherapy, second line use immune checkpoint inhibitors. What beyond that? And what is the data for first line immune checkpoint inhibitors followed by a second line options? So coming to the second line options prior to immune checkpoint inhibitors, for combination therapies, we had the docetaxel plus ramucirumab, docetaxel plus nintedanib, and paclitaxel that is weekly, along with bevacizumab, and of course various single agents like gemcitabine, pemetrexed, single agent docetaxel, or even afatinib in squamous cell carcinomas. So the REVEL trial data showing the docetaxel plus ramucirumab versus docetaxel plus placebo compared these two in stage 4 non-small cell lung cancer who had received prior platinum-based chemotherapy. And there was a modest 1.5 months improvement in the PFS, but also improvement in the OS, which was statistically significant, though the duration was very small. Similarly, the LUME-1 trial used the nintedanib along with docetaxel in patients who had already received first-line platinum therapy, compared with docetaxel with placebo. And here again, as we can see on the right side, the overall survival in the adenocarcinoma was quite significant, with about 3.5 months of overall survival benefit, and also a small PFS benefit in the entire intention to treat population. So this slide shows the comparison of the various response rates, the median PFS and OS for single agents as well as for the combination therapies in the second line setting post platinum-based chemotherapy. And we can see that the combination therapies have got a better OS and a PFS advantage. A very busy slide, but a good slide just to compare the various options available for treatment in the second line on the x-axis versus the same on the y-axis. It is a kind of a heat map where the ones in the blue are showing the negative kind of results, whereas the ones in the yellow show positive results, and one in the red showing the most best results of all the second line therapies available post platinum-based chemotherapy. Coming to the second line options, or other third line options after second line use of immune checkpoint inhibitors. So does chemotherapy after immunotherapy offer a better overall response rates? So there were a few studies, and I'll show a couple of them to show that the chemotherapy after immunotherapy does offer a better overall response rates. So published in 2017, this data are small numbers, 28 patients, with the overall response rate after immune checkpoint inhibitors was about 39%, whereas prior to immune checkpoint inhibitors, the response rate was about 37%, just a numerical advantage. Another paper published in 2017, again showing whether the salvage chemotherapy administered after immune checkpoint inhibitors has an increased response rates. Here, they had about 73 odd patients, and they showed that the chemo in doublet after immune checkpoint inhibitors has got a higher overall response rate than to the last chemotherapy before immune checkpoint inhibitors. Again, both single as well as in doublet, the overall response rate is higher, both statistically significant. So it proves that the overall response rate for salvage chemotherapy after immune checkpoint inhibition is significantly higher than the last chemotherapy before immune checkpoint inhibition. Now coming to the data for second line options after first line immune checkpoint inhibitors. So the two studies recently published, 2020 and 21, treatment of first-line immunotherapy, options after first-line immunotherapy. They were there, they did show some benefit. I'll just come to that. Just going back to the combination of docetaxel and ramucirumab in the second-line setting after use of chemoimmunotherapy. So now we're talking of the same kind of combination after a platinum combination, and now talking after immune checkpoint inhibition. So here, they used it as a doublet in 18 cases and a single agent ramucirumab in over 15 patients. Overall response rate of 55.6% with the doublet. What they found was patients who had had a response of more than 8.8 months with chemoimmunotherapy had a very high PFS advantage as compared to those patients who had less than 8.8 months of response after PFS with chemoimmunotherapy, which means that the duration of response to chemoimmunotherapy may allow us to use this combination in these patients. The previous speaker very beautifully alluded to the tumor microenvironment and what happens at the tumor microenvironment. So whenever the tumor grows, there is intratumoral hypoxia, leads to production of the hypoxia-inducible factor, leads to the production of the VEGF, and leads to the abnormal vasculature, the malformed and malfunctional vasculature in the tumor. Now, this abnormal vasculature leads to some kind of an immunosuppressive effect. There is effect on the endothelial cells. There is reduced antigen presentation by the dendritic cells. There is polarization of the tumor-associated macrophages, where they move in from an immunosupportive to an immunosuppressive kind of a phenotype. And of course, there is increased production of Treg cells, all of these adding to immune suppression. So does the immunotherapy, which is given in the first line setting or even the second line setting, does it modify the microenvironment for an anti-VEGF? This was pointed out very beautiful in the previous speaker, Dr. Peters. Just let's look at the relation between the VEGF and the immunotherapy agents. There is a relation where the use of immunotherapeutic agents leads to an interferon gamma mediated vascular remodeling. And this adds to some amount of effect with the anti-VEGF. Thereby, the use of anti-VEGF in the second line may lead to further remodulation of the tumor microenvironment and causing immune trafficking, leading to a better response with a rechallenge probably with immune checkpoint inhibitors. But is there data to that? So there is this paper which has used the same docetaxel and ramucirumab following second-line immune checkpoint inhibitors in non-small cell lung cancer. And this table has compared the docetaxel nintedanib and docetaxel ramucirumab in a single table. The arrows point to the third-line use of these drugs post second-line ICI. What you can make out is the very high disease control rates and the response rates compared to the second-line therapy which was used. So it does mean that when immune checkpoint inhibitors have been used in the second line, the use of anti-VEGF drugs beyond that does have an increased response rates as well as disease control rates. So the use of immune checkpoint inhibitors leads to some kind of a vascular normalization, thereby enhancing the effect of anti-VEGF. The use of anti-VEGF agents used to an immune activation, leading to a better effect of the immune checkpoint inhibitors. Using them in combination is what was a previous speaker alluding to, does have a benefit of using in the tumor microenvironment, and that explains the effect. So probably we are seeing a new sequence in the horizon where we use chemoimmunotherapy in the first line, which leads to modulation of the tumor microenvironment, allowing the chemo plus anti-angiogenic therapy agents to act better. And this anti-angiogenic therapy, when it modulates the tumor environment further, we may have a better option to re-challenge with immunotherapy.
20 seconds.
For ICI beyond progression, and atezolizumab, the data with pembrolizumab as well as with nivolumab, but this slide just showing the atezolizumab beyond progression, showing the increased survival advantage even beyond progression. A lot of newer agents, due to lack of time, I just put on one slide, the lenvatinib plus pembrolizumab versus docetaxel being compared in a phase 3 trial. The sitravatinib, again, multi-agent kinase inhibitor against TAM family, as well as the regular VEGF and the PDGFR alpha, showing a disease control rate of 84% in initial trials. Cabozantinib is being tried in a phase 3 trial. And of course, the IL-2 agonist is being tried with pembrolizumab in a PROPEL trial and with nivolumab, as well as with nivo-ipi combination in PIVOT 2 trial. To summarize my last slide, whenever there's a progression to a non-small cell lung cancer patient after use of immune checkpoint inhibitors or with combination chemotherapy. If there is an oligoprogression, maybe the local ablative therapies can help in maintaining the response. If there is systemic progression, if there is a primary resistance, there is early progressive disease, these patients require probably a clinical trial or a rebiopsy to see the change in the morphology. If there's an acquired resistance, if it is an early or an intermediate progressive disease, various combination strategies with the anti-angiogenic therapies can be tried. If it is late progressive disease, beyond 2 years, beyond 1.5 years, progressive disease terminating after ICI, we can re-challenge the immune checkpoint inhibitors, or progression during the therapy, we can re-challenge with a change of the chemotherapy. With this, I finish my talk.